Now we will start our next workshop on high tibial osteotomy, and I invite Professor Milind Chaudhary and his team, Dr. Ishani Chaudhary and Dr. Jijesh, to please come on the stage and let's have another wonderful workshop on high tibial osteotomy. Thank you.
Hi, good afternoon, friends. As we are gently shifting gears from the magic of Kurgan, I would like to welcome you all to this workshop on high tibial osteotomy. It's going to be a brief introduction. So first of all, my many thanks to Professor Rajat Agarwal, the President of Asami India, for kindly giving us this opportunity, and for Nebula Surgicals for arranging this. So, we're going to have a couple of talks and then we will have 2 workshops. A couple of talks will introduce you to some of the newer concepts in high tibial osteotomy. So I'll be joined by Dr. Ishani Chaudhary, Professor Jijesh from Kozhikode, and then for the workshop, it will be my great privilege to have so many great experts who are here, who have been working with the Elizarov method for such a long time. Professor Srinivas Reddy, Amar Soni, we'll have Dr. Saurabh, Dr. Neerav, Dr. Akrut, Dr. Goda Siri. So many of you are now big experts, and so many big experts are here. Vikas is here, Professor Suresh is here. So you can help the people with the concepts of multiplane. So without further ado, may I invite Dr. Ishani to give us a very brief introduction. A very brief introduction to the terminology. That's the, the alphabet soup of the...
A very good afternoon. First of all, thank you very much to everyone who's present here. Thank you to the President of Asami India for having us. And thank you for all the professors who taught us before for a very educative workshop. Let's begin this HTO workshop with a flow, a gentle flow. So we'll introduce a couple of terms that we'll be using. This is a very basic talk so that we're all on board. Alright, so everyone knows this. This is the mechanical axis deviation, which we find out after knowing what the mechanical axis is. That's basically the Mikulicz line or the weight-bearing line. And that is what shows the overall alignment. Now, mechanical lateral distal femoral angle, which is around 85 to 89, is the angle between the femoral mechanical axis and the knee joint line. Anatomical medial proximal tibial axis, which is 85 to 89 again, is the angle between the anatomical tibial axis and the knee joint line. The mechanical medial proximal tibial angle, that is the MMPTA, which is the angle between the tibial mechanical axis and the knee joint orientation line. Then comes the posterior proximal tibial angle, 78 to 82 degrees, which is the angle between the tibial anatomical axis and the posterior tibial slope. Then is the MLDTA, which is the mechanical lateral distal tibial angle, 86 to 90 degrees, which is the angle between the tibial mechanical axis and the ankle joint orientation line. Alright, so a couple of terms here. So that is the JLCA, which is the joint line convergence angle, which is the angle between the distal femoral joint line and the proximal tibial joint line. Now, when you give on stress X-rays, you will find different JLCs. So there's a varus JLC and there's a valgus JLC. Make sure to take a note of this. And then we have something known as the joint line orientation, which is basically the knee joint line orientation is the angle made by the inclination of the knee joint with the ground, which is indicated by that. This is assuming to be the ground. And next is the ankle joint line orientation, AJLO, which is the angle made by the inclination of the ankle joint with that of the ground. Now, just a couple of terms. We'll be hearing them again and again. So I'm just starting out with the keys to this entire map, which is the EAO, which is the extra-articular osteotomy. So in that we have the medial opening wedge high tibial osteotomy, that is MOWHTO. Then is the LCWHTO, that's the lateral closing wedge osteotomy. Then is the FDO, that is the focal dome osteotomy. DFO, which is the distal femur osteotomy. Now we go into the intra-articular osteotomies. So what we have in that is the tibial condylar valgus osteotomy, the FDCO or the focal dome condylar osteotomy. And then when you mix it up, that's the double level osteotomy or the DLO. Take it up a notch, that's TCVOI is basically tibial condylar valgus osteotomy with a focal dome osteotomy with the Ilizarov. Alright, so that's the basic introductory talk. Now we'll be figuring out why and where to do which of these osteotomies. I'd like to invite Dr. Milind Chaudhary to give his algorithm. Thank you.
So now that we are familiar with the terminology, all of us are under the impression that there's only one or two good high tibial osteotomies, whereas the truth is, all of us perform different roles in life. We are all over here, husbands, fathers, brothers, administrators, sports persons, educators, teachers, and we all behave in different ways. So we don't carry the same behavior forward in all the various aspects of our life, as Shakespeare would have said. So how do we choose the algorithm, which high tibial osteotomy for which patient? So firstly, you must know that the knee joint cartilage can regenerate. This is from Professor Koshino, and this is 1.5 years after. So this is in memoriam to Professor Koshino. I'll have Professor Rajat and Agarwal know that in 2010, Professor Koshino came to Jaslok Hospital, Mumbai, where as president of Asami, India, I hosted the very first conference on HTO. So we know today that 90 to 100% of the literature is only based on medial opening wedge, whether it's an acute correction like this, or whether it's gradual correction using an HTO fixator. But we know we need different osteotomies based on the location and severity of the different deformities. We have deformities that increase in severity and come to us in our OPD with knee pain, medial compartment arthritis, with increasing amounts of deviation of the mechanical axis, like as is obvious. So the question is, can one osteotomy correct all of them? Obviously it can't without creating new problems. So perhaps what we need is a different set of osteotomies and the judgment to decide which one to use where. So for the last 34 years, I've been performing 6 different osteotomies. The first is the focal dome osteotomy described by Dror Paley in OCNA in 1994, which is a curved dome osteotomy with the Ilizarov fixator, which allows us to correct large deformities. Then came the opening wedge, medial opening wedge with the Tomofix system, which is very popular since the year 2010 or 11 for very many reasons, for the comfort it offers to middle-aged ladies. Then comes the distal femoral osteotomy, which is gaining rapid popularity of late as we discover that more people need only the femoral. Then the last 3 that I'm going to talk about are the intra-articular. Dr. Ishani alluded to them. This is the TCVO started by Professor Teramoto, which we will be briefly alluding to, in which it's an intra-articular medial tibial condylar elevation osteotomy, like a hemi-plateau elevation that's done in Blount's, so that the incongruity of the joint is corrected. And then for the really large deformities in which there is an intra and an extra-articular component, we are going to correct both the intra and the extra-articular. And nothing but the Ilizarov fixator can help us do this very elegantly. In men, it's okay, but sometimes in women with these large deformities, with this component, both components, it doesn't work. So this is just for your reference. We won't be describing it today. This is the focal dome condylar osteotomy, which is an elegant solution come out of Japan in 2020, in which it's an intra plus extra-articular osteotomy. With a single osteotomy, you can correct both the deformities. So briefly, these are the extra-articular, the medial opening wedge, the focal dome, and the distal femoral. And these are the intra-articular, the TCVO, combined with the extra-articular and the FDCO. So how do we choose? We choose by the location and severity of deformities based on radiological and clinical criteria. We categorize them as a primary deformity, which is a coronal plane varus, which is determined by the mechanical axis deviation, by MPTA, by MLDFA, and by the hip-knee ankle angle. So it may be small if the mechanical axis deviation is greater than 0, meaning that the MAD mechanical axis falls within the joint line, or large if it falls outside. Now the secondary deformity that you are not aware of, not have heard of mostly so far, is the intra-articular deformity. It has two parameters. There is incongruity and instability. So far, we have only heard about alignment. Now, these are new criteria. You can get familiar in greater detail later, incongruity and instability. And the two measurements are CPA, that's the condylar plateau angle, and the JLCA. We all know the JLCA, which Ishani pointed out. This is the mismatch between the two condyles. This is the JLCA. And this is the condylar plateau angle. In its extreme form, it resembles the pagoda tibia. That's the angle the two tibial condyles make to each other. In Blount's, it's an extreme depression, but in many patients with osteoarthritis of the knee too, they have varying degrees of CPA. So these are the angles that are needed, but we won't be discussing this in much detail. And then comes the tertiary deformities in the sagittal plane, that's a flexion deformity of the knee. In the axial plane, which is either shortening or over-lengthening, because there's something known as a long leg arthritis, right? You've heard of this. And there's the rotational deformities, which are also very common component of osteoarthritis. So these again are the tertiary deformities. In brief, the sagittal axial rotational, procurvatum or recurvatum, short or long internal or external rotation. So what's the algorithm based on these criteria? So if you have a small primary varus deformity, but you don't have a secondary intra-articular, don't have a tertiary sagittal axial rotational, you need the opening wedge or the closing wedge in the tibia. Both will do well. So in small deformities like this, you can do this. This is an orthopedic surgeon. He's very fitness conscious. Look at the small deviation, extreme problems he had. So he wanted this more about him later. So we just correct him beyond the neutral with a tiny one with the tomofix plate. Works wonderfully well. And this is the kind of, activity levels you can expect. I'm sorry, the video is not working. We'll move on. So we know now that there's no one point, there's no one Fujisawa point that governs us all. You can just bring it to neutral and the articular cartilage composition can improve. What if you have a large varus, no intra-articular, but sagittal axial and rotational deformities? Then you are better off performing the focal dome osteotomy. Now, all of you are fans of the Elizarov method, and today we have the opportunity to learn this extremely powerful osteotomy, the focal dome osteotomy, which allows you to correct, the length, rotation, and the sagittal plane, as well as a large deformity without losing bony contact, without having any significant disadvantages. So this is the focal dome. We are familiar with the Mackay dome, in which the cora is kept below wrongly. So the osteotomy is above, and therefore it resembles a frowny face. And there's also some medial translation of the distal fragment, which is counter opposed to what we want to achieve. We want to achieve a lateral translation of the mechanical axis. Whereas a focal dome with the cora in the right place, and this is rule 2 of deformity correction, you get it to translate laterally. So this is the example. Somebody like this is a bodybuilder, is 65. He has rotation, a lot of varus. So we don't want to, perform an opening wedge. We perform the focal dome. It's in very good contact laterally. We can give compression with the Elizarov and they do really well. Now, if you have an intra-articular and it's a small deformity without tertiary, then we perform the TCVO. As I said, what the mind doesn't know, the eye cannot see. So how do we diagnose the intra-articular? Clinically, if it's a large varus, suspect it. If there is a dynamic varus and a mediolateral laxity on examination, you can confirm it. So in this, this is the mediolateral laxity in the knee joint. On gait, this is the dynamic varus or the lateral thrust. And also recorded on the C-arm is the mediolateral teeter and opening closing. Radiologically, you see increased MAD, increased JLCA, and increased condylar plateau angle. Like this, the MAD, the large JLCA, and the large condylar plateau angle. And the TCVO will work by elevating this is the teeter, totter, and point contact, which increases the forces. You perform an L-shaped osteotomy. It reduces the teeter, improves the stability, and you may get a decent correction. So this is an example. You can see this. Now that condyles are collinear in middle-aged ladies, it's very common to see this. And we've been doing since Asami International 2014, which Professor Junjunwala was the president, and I was the chairperson of the scientific committee, and Professor Teramoto came and taught us this. So this is the teeter effect, which goes away because you get simultaneous contact. So it corrects the MAD modestly, corrects the intra-articular, and doesn't overcorrect the MPTA. If you have a large deformity of varus, but no tertiary and an intra-articular component, then I told you about this focal dome condylar, this is the article in 2020. This is lateral to the tibial, patellar ligament, and it's a 2-in-1 procedure for a 70-year-old physician. What she needs is no external fixator, because they don't all tolerate, we know this, they don't all tolerate external fixators, and we can do justice to this with this osteotomy by completely correcting both the components like this and get a very good correction. And finally, if you have large deformities in the varus, secondary and the tertiary planes, then you need this wonderful Ilizarov assembly in a patient like this. He has got the intra-articular, so he gets a tibial medial condyle elevation and a distal dome osteotomy with minimum lateral translation, to give him this very adequate correction of the mechanical axis where it is needed, like so. So this corrects all the components of the deformity, and this is the algorithm in summary, which describes how we choose different osteotomies. Now we've left out the distal femoral osteotomy, and we use this. This is an orthopedic surgeon. He has severe pains. He has, of course, advised a total knee, but he didn't want one. On careful analysis, there isn't much varus valgus deviation, and he's got 95 degrees MLDFA and no deformity in the tibia. So what he needs is a distal femoral osteotomy like this. You can see this is the modern distal femoral osteotomy, closing wedge with the Tomofix plating system, and he got this very correct, just 55 degrees, and he's doing extremely well with no pain. Resumed his OPD in 3 weeks, and he's zero pain, met him at a conference, and he has no difficulties whatsoever. If you have a combination of the femur and tibia deformities, then what you need is a combination of both of these, which helps us to do this so as not to place excessive load on the joint line orientation. So this is described by Babis and then by Saragaglia, and then recently it's the flavor of the season from Germany, and this is from Nakayama. So you can do this. So you see this person has got this very bad gait, is in extreme pain, large deviation, and they don't always tolerate the Ilizarov well. So you do the distal femoral osteotomy and intra-articular tibial osteotomy, and here he is with his completely corrected mechanical axis without overcorrection and complete relief from pain. So I will end this talk, this brief introductory talk, by recommending to you that each one of us can develop at least 2 to 3 osteotomies. That's going to help us tackle and keep them in your armamentarium, develop them, because it takes a while to get familiar and become an expert from being a tyro, which is a beginner, to a virtuoso, who is an expert. It takes a while. So you develop 2 or 3 osteotomies, and that's going to help you to tackle the vast majority of the cases that come to you with medial compartment osteoarthritis of the knee. So in today's workshop, due to the limited time, we are going to focus only on 2 osteotomies: the medial opening wedge performed with a plate, in which we are going to demonstrate here, and the Ilizarov focal dome, which we are going to demonstrate as well as have you perform it. So may I invite Dr. Ishani to speak briefly about the digital planning method for medial opening wedge high tibial osteotomy when performed with a plate. And after that, we'll have Professor Jijesh. She's going to be very brief with this. After her, we'll have Professor Jijesh tell us about alignment and So patellofemoral joint very frequently is arthritic, and we can easily deal with it by performing a retinacular release, a medial and a lateral retinacular release. You can remove osteophytes from the patellofemoral joint, and that's going to, by releasing the patellofemoral retinaculum, you're going to increase the range of motion, reduce the patellofemoral pain, and improve the range of motion. Secondly, in the lateral compartment, you have to, of course, make sure that there's no lateral compartment tenderness. That's a contraindication. And tenderness, very carefully elicited, is a very good yardstick of determining whether the lateral compartment is arthritic. If it's indeed arthritic, not just go by osteophytes. The mere presence of osteophytes in the lateral compartment doesn't necessarily state that it is lateral compartment arthritis. So when we perform the osteotomies and we do a retinacular release, we can actually peep inside the joint and see that in a vast majority of cases, the lateral compartment is fairly good. So I'll now leave it. Yes, sir. Yes, Professor Moil. Yes, sir. So the low varus, as I showed you in an orthopedic surgeon, we opened a wedge of only 5 millimeters. So the other thing that you have to look for in a very small varus with pain is you have to look for an intra-articular component, which used to flummox us long ago, you know, how to do this. And then you end up over-correcting badly. So they have intra-articular, or you just correct beyond neutral in a low varus. High varus, we showed you multiple modalities, sir.
Professor Milind, there are two questions. Sorry
Yes, sir.
for interruption.
No.
One is that what is your criteria till what grade you do high tibial osteotomy? Like if it is grade
Yes, sir.
1, what is your criteria?
Kellgren-Lawrence grade 3 and 4 are accepted for performing a high tibial osteotomy. The vast majority of literature now coming out of Japan is all of them are Kellgren-Lawrence grade 3 and 4. Most of my patients are KL grade 3 and 4. So it's no longer a contraindication. We have advanced the literature from Germany, the literature from Japan, and our experience in India. As you very well know, our patient population comes with later grades.
And my second question is, would it not be, sometimes do you use arthroscopy also to
Yes,
clean
sir.
up the joint before?
Yes, sir. If there's
Does it
any,
give a better result?
it could. If you're facile with arthroscopy, definitely. We peep into the lateral compartment. We removed bucket handle tears. We removed large loose bodies. You can remove the osteophytes from within the joint. If you have any doubt in your mind, if you have, you're familiar with imaging. If you do a degeneric cartilage specific cartogram on the lateral side, if you have severe damage, or if you have any doubt, you do a PET CT scan, and if you have an increased uptake in the lateral compartment, then that becomes a contraindication. In my experience, 1 out of 100 is contraindicated. Yes, sir. Yes, Professor Bari.
I have two questions regarding this. What's your comment regarding the fibulotomy only?
Sir, I wanted to say some things we are not going to discuss.
Okay.
And I'll take the privilege of going ahead with the program because much needs to be done. Please excuse me.
Okay.
We'll go ahead with the next talk. Thank you.
So now that we have a new strategy of dealing with knee osteoarthritis, which is these various types of HTOs, let's zoom in and get to the digital planning for the medial opening wedge high tibial osteotomy. So why is it essential? So failing to plan is essentially planning to fail, and we absolutely don't want to do that. And for that, we have something known as digital planning, which gives us reliable, accurate, and reproducible results. And that has been adequately documented in the literature. So what all do we need for digital planning? Whatever is your PAC system is good enough. I'll be taking you through what we use, which is basically the CareStream image suite. We're going to be teaching you the basic steps so that you can apply it to whatever PAC system that you're using back home so that it's applicable for you. And I'll be taking you through the general flow so you can use all of these steps and use it back home. Now, obviously, we need the full-length X-ray. After that, we have two methods. One is the Miniachi method and the Dugdale method. What we'll be referring to today is the Miniachi method, wherein I'll be taking you through the details of it soon. In case anyone wants to know what the Dugdale method is, it's basically when the line goes through the intended axis from the center of the hip and one from the center of the ankle. Now, we're not going to be referring to this because we know that the Dugdale method leads to undercorrection. So we're not going to refer to that. What we'll be using is the Miniachi method. And now let's get to it. So I'll be, to figure out how to do the digital planning, I'm going to answer 3 key questions for you. That is, how do we do it? So for that, what all do we need is the long leg film. Now, we start off with step number 1, which is we need to calibrate the magnification marker. So whatever magnification that you use, you make sure that you have taken the size of it. You know the original size and you know what is showing on the X-ray. So in this case, it's 25.73. Then you find out, step number 2 is you find out the magnification factor, which is you divide the original size divided by the X-ray measurement of that magnification marker. Here in this example, it is 25 divided by 25.73, which is 0.97. Next, we figure out the mechanical axis. Now, how do we draw the mechanical axis? We zoom in on the hip. Make sure that in digital planning, this gives us the opportunity to zoom in and give like accurate planning. So zoom in on the hip, mark the center of the hip with the pointer tool. Then you zoom in on the ankle. Then you find the ankle center. And now you pass a line from the center of the hip to the center of the ankle. The reason I'm saying this is approximate is because you'll zoom in again. This is one tip that Dr. Milind recommends to me and all his fellows, is that you make the effort to go back and zoom in again and make sure that your pointers are exactly in the center for the best results. And then you go back again and you'll find that maybe there's a very slight error. So make sure that you correct it, and now that you have an accurate center. And now we have the mechanical axis, which is shown by this blue line. And what we're going to do is, using the line ratio tool or whatever tool that you have in your particular software, you can use and figure out where exactly is it at what percentage. Now, in this example, it's at 32%. So, how much do we correct? How much do we correct the mechanical axis? Dr. Milind just spoke to you about opening our minds to the concept that there is of course a Fujisawa point at 62.5%, but we open our minds to the concept of customized correction, where it's not just a single point, but it's a zone where we can correct. And that is based on the amount of cartilage loss. I'm sorry, the presentation is running away. Alright, so in case there is mild cartilage loss, let the new axis pass from 50 to 55%. When there is moderate cartilage loss, let it pass from 55 to 60%. And when there is severe or bone-on-bone contact, you can go through 60 to 65%. And that's why we refer to it as a zone. Alright, now in this case, for this patient, we're going to go through the intended axis at 55%. Now, what we do is, we have the original mechanical axis in blue, we draw the intended axis, which is shown in yellow. Now, again, zoom in again, make sure that you are accurate. Okay, so now what it gives us is, once we've drawn these, you go down all the way to the ankle. So first was the original ankle, the center of the ankle, then you get what is known as the future ankle, where the intended axis comes around the ankle. Now comes the first important angle or measurement that we have here is the angle of correction, or alpha. That is, how much do we correct in terms of the angle. That is measured by, to calculate that, we'll find the angle between the line joining the ankle center to the hinge point and the line from the hinge point to the future ankle. Now, we're talking about the hinge point. So, where should the hinge point be? So, just above the level of the superior tibiofibular joint, in the tibial head, mark the hinge point stopping 5 mm short from the lateral tibial cortex and about 10 to 15 mm from the lateral joint line, depending upon the size of the tibia and the size of the patient. Now, again, we're talking not just specific points, we're talking zones. So, the ideal zone that you want to be is somewhere here, which is within the proximal tibiofibular joint and lateral enough. Next, what we're going to do is, now that we found in this case the angle was 4.7 degrees. Now, we're going to take this angle and we're going to shift and mark it out there on the medial tibial cortex. Okay, now the point where we start the osteotomy on the medial tibial cortex is going to be somewhere around 35 to 40 mm from the medial joint line. Alright, that's, if I had to give you an anatomic marking, that's where this contour changes. Okay, so convexity changes just beyond the pes insertion. Now, what you will draw at that point of time will be an oblique line, but we are not going to take the oblique line. Remember to drop a perpendicular. So the perpendicular is going to be the distance that you will have to open. So in this case, in this example, it's going to be 5.1 mm. How much do we open? Is it going to be 5.1 mm? The answer is no. We are going to actually end up opening, because we forgot the magnification factor in the X-ray. So we're going to open according to the perpendicular distance, taking the magnification factor into account. So in this case, it's actually going to be the measured 5.1 and the magnification factor, which is going to give us 4.94. So this is a particular example, but I just wanted to make sure that we don't forget the magnification factor. So overall, these are your steps, or this is your flow of the digital planning. You find out the magnification factor in your X-ray, draw the mechanical axis, draw the new intended mechanical axis depending upon the grade of the osteoarthritis, figure out what is your future ankle, find out the alpha angle, subtend it from the hinge point onto the osteotomy location, and then find the perpendicular distance, and by taking the magnification factor here, find out omega, which is the amount of opening. Is there anyone who's using automated softwares for your planning? Anyone in the audience using automated softwares? If not, I won't, there's a lot we have to learn, so I won't go through this, but I hope that this was helpful and helped you practically understand the step-by-step procedure for planning your medial opening wedge high tibial osteotomy. Now let us learn how. Thank you. Next, I would like to call upon Professor Jijesh to talk to us more about the preoperative planning of the HTO. Thank you, sir.
Good morning to all. First of all, I would like to thank the organizers and the President and Secretary and Melin sir for inviting for this talk. So I am going to discuss about preoperative planning of HTO. So this is what John Charlie said about planning. Failing to plan is planning to fail. So always plan before doing any surgery. So the goal of HTO surgery is to preserve the knee joint, and so that you can delay the need for TCAR for as long as possible. So first and most important thing is the clinical evaluation. So this is most important to decide whether you are going to do the HTO or not. So ask for the pain characteristics present on medial side only, while walking only, or all times, or standing from sitting position. All this you have to ask, and whether there is a deformity present or not, varus deformity or flexion deformity or medial joint and all this you have to check. And the range of motion, of course, and you have to check whether lateral thrust or laxity, ligament laxity is present or not. Then you have to do the stress test, valgus stress, whether coming to neutral, or if there is a lateral cartilage loss is there, it may go to lateral side. Similarly, you have the medial side cartilage loss, you can find out by the varus stress test. Next thing is to find out the deformities. What are the deformities also of this? So sometimes you have femur only or tibia only, or in a combination of both these. It may varus tibia with a valgus femur, or a varus tibia with a varus. Then a lot of combination can occur. These things you have to find out before you jump into do the surgery. And the joint deformities are mainly due to the ligament problem, the LCL laxity, MCL laxity, or a plate depression like a post trauma or a Brown's disease, etc., and lateral subluxation, patella maltracking. These are the things you have to find out before you go for the surgery. In the investigation part, these are the X-ray you have to take. There is an X-ray both in standing AP and X-ray both in standing PA in 30-degree flexion to assess the proper joint space. Already you must be knowing the Kelliger and Lawrence curve. That is 0 to 4, So that you have to see whether what stage it is. Then you have to take the X-ray full extension, lateral view, to assess any sagittal plane deformities are present or not, and the patella maltracking is there or not. Then the stress X-rays. So already clinically you had examined like that. Stress X-ray also you can take valgus and varus stress X-rays. So these reveals, that is varus stress reveals the medial cartilage joint space, and the valgus stress reveals the lateral joint space. Suppose the patient JLC is and neutral, it is 5 degree, and in varus stress it is 10 degree. That means a 5 degree extra is due to the cartilage loss. So this is the importance of the stress X-rays. Then you have to take the full length X-ray, which is the most important step in doing the HTO. So you have to measure all the angles, and you should know how to take the X-ray. And the position is most important. Patella forward positioning is the most important. Otherwise you will end up with a trouble. So in this case, a valgus girl, the X-ray you can see the patella is not centered, so the deformity was in the femur. So when you take the X-ray in the patella centered position, it was in the tibia actually. Similarly, the another X-ray where you can see if you patella centered X-ray and the patella non-centered X-ray. Next, once you have done the full length X-ray and the assessment, next step is the malalignment test. So first thing is the mechanical axis deviation, whether it's a varus or valgus. So we have to draw from the hip joint center to the ankle joint center. Then the next step is to measure the LDFA by drawing hip joint center to the knee joint center and a joint line, that is LDFA. Already told about these things. That is LDFA normal is 85 to 90. Similarly, you have the MPTA. MPTA is you have to from the knee joint to the ankle joint and joint line. That angle is the MPTA, normal it is 85 to 90. And JLC also you have to draw by drawing two joint lines. And you should know all these angles, mechanical and anatomical angles, LDFA, MPFA, PPT, all these things in both coronal and sagittal plane deformity you should know to find out where exactly deformities or a combination of deformities. And rule out knee joint subluxation. So you have to find out by drawing, you mark the center of the both condyles and to see that is there any more than 3 mm difference is that means joint subluxation is there. And condylar malalignment, this is also important. You cannot draw a joint line from, in these cases, from middle to lateral. So this is a depressed joint, maybe in the, you will get in post-trauma or in Brown's disease, etc. So when a patient comes, the first thing is the malalignment test. So here, joint line, mechanical axis, joint, then JLCA, then find out the LDFA by femur and tibia. So in this case, you can LDFA is 88, MPTA is 81. So the main problem is in the tibia. So once the bones, which bones are identified, next step is to find out the cora, where sometimes the deformity may be in the femoral shaft, may not be in the metaphyseal region. So in such cases, you have to correct the diaphyseal deformities. So next step is how do you find out the magnitude of correction. So you have to find out the cora, the angles, everything. But how will you correct? What angle you have to reach? The answer is the amount of angular correction is angular deformity of cora plus the JLCA plus the overcorrection. What is the overcorrection needed? So what should be the final angle to find out the overcorrection? So there are a lot of studies regarding this. The consensus is 2 to 6 degree. That should be the final mechanical axis. So why 2 to 6 degree? Why not more than that? So this only will understand by the force distribution around the tibial condyle. So normally the tibia is mechanical, tibiofemoral axis is the 2 degree varus. So the force is in 2 degree varus, it's the normal, it is 75%. And when it is comes to the valgus side, you can see that in the 4 degree angle it is around less than 50%. So that is the force distribution. Even 1 degree of can cause a tremendous force on the medial side, but lateral side it is less. So Fujisawa recommended overcorrection angle, that is called the Fujisawa MAD and or Fujisawa point. So that is a 30 to 40% of the lateral to the center of the tibial spine. That is the Fujisawa MAD. So that the Murphy and modified this. That is based on the amount of cartilage loss remaining on the medial side. So suppose there is no medial cartilage loss is there, then the MAD should be through the 0. That is you can pass the final mechanical access through the center of the knee joint. Suppose a 1/3 loss is there, so that's the 1/3 physis over point, like that 2/3 or full MAD. So that is about the final future mechanical access. Then the osteotomy position, how already described, that is from the medial side to lateral side. In oblique fashion you can do if you are doing a plate or orthofix, but focal dome osteotomy is a different thing. And this is 3 centimeter down to proximal to the proximal tibial tip. So Miniasi method already told to find out how to calculate the wedge of base. So draw the mechanical axis, draw the future mechanical axis, and draw the axis of from tibial center to the tibiofemoral joint, and from there to the future mechanical axis. That is the alpha angle. So to find out the wedge of the bone to remove, so you can draw you can find the length, measure the length of the osteotomy and mark it on the L1 and L2 on the there you can calculate the wedge. So same you can apply on the tibia also. So Dugdale method is another method which already described. Now this is the most important thing. When a patient comes to you, what are the steps you have to do? So each and every case you cannot directly go and do the HTO. So it's a customary approach to HTO. That is called the a la carte approach. So what are the steps? Which already described, that is when a patient comes to identify the malalignment test, whether it is a femur or tibial osteotomy is needed or both, or identify the cora, then decide the type of osteotomy and the magnitude of correction and type of fixation. This is the steps. So when you draw a malalignment test, sometimes most of them it will be in the tibia, sometimes it will be in the shaft of femur or in the metaphyseal region of the femur. And the problem comes when it is mainly due to the cartilage loss or a JLCI is increased without any femoral or tibial deformity. There you will be in confusion. So how to decide which bone needs to correct? When there is an absence of significant LDFA, that is mainly in the tibia, you can go ahead with the tibial osteotomy. When the LDFA is mild and abdominal MPTA, that is in the more of valgus range. So there you can do the femoral osteotomy. When the LDFA is mild but MPT is virus to end of the normal, there you can do the tibial osteotomy. When the MPT is on the virus end of the normal and the LDFA is normal, there you can do the tibial osteotomy. When LDFA is clearly virus more than 93 or mild valgus or mild virus, but MPT is on the valgus side, there you can do the femoral osteotomy. When LDFA is slightly virus, but MPT is at the virus end of the normal, that is tibial osteotomy you can do. And LDFA is in valgus side, and the MPT is that is less than 85, and the MPT is in virus side, that is less than 85. So what will you do? You have to do the both femoral and tibial osteotomy, because valgus femur and virus tibia is a particularly dangerous combination. There you have to correct both. So you cannot keep valgus and a lesser corrected tibia. So that combination will give you a future arthritis. So when LDB is clearly virus and then MPT is clearly virus, so here also you have to do the both osteotomy, femoral and the tibial osteotomy. So overcorrection of the tibia when the femoral virus is present obviates need for second. That is a dictum. But you can do the overcorrection maybe up to 5 to 6 degree, because more than that if you do on the tibia, what will happen is a joint line obliquity can occur. So better to do when more deformity present, you do correct both. But under correction of the virus, when the femoral valgus is present, you cannot do you have to do the two osteotomies. So because valgus femur and the virus tibia combination are bad. So the pattern of mild virus femur with a mild valgus tibia is a well tolerated balanced mix. Therefore, it is responsible to create this type of intentional knee joint up to 5 degree femoral virus. Whereas under correction of the virus tibia related to the valgus femur is not well tolerated. So this is an example, is an old man. You can see that one side femur tibia is MPT is virus side, but femur is normal. On the other side, the valgus femur and the virus. This is a bad combination. So that is all about the how to decide which bone you are going to do osteotomy. And the implants of choice is your surgeon's preference. But exact post-operative alignment is prerequisite for the longest possible relief of symptom in MCA. So you can correct, main disadvantage of acute correction is the failure to achieve the desired correction more than 50% of the cases. So the implant of choice can be either fixator, HTO, plates, or HTO with Ilizaro, or you can decide whichever you want. So, but the ideal solution should deal early correction, that is accurate correction, and leave option for the TCAR. That should be your aim. And already a digital planning you have learned. So this is also you can do from the Bone Ninja. There is an iPad. It is available. You can do the find out the Cora and all this. You can do in the iPad. So the conclusion. Clinical evaluation radiological assessment is the most important factor to decide about H2 in particular patient. In a la carte approach should be recommended. Pre-operative planning is most important. Exact post-operative alignment is the key prerequisite for the possible relief of symptoms in MCOA. And the implant of choice depends on the multiple factors and surgeon's choice. Thank you.
Thank you so much, Professor Jijay sir. Thank you. We probably should have had your talk before Dr. Ishani's. So now there's going to be a slight change. We will have a very brief talk on the technique of medial opening wedge. Then we will demonstrate. We only have one workstation for the plate. So we will demonstrate the medial opening wedge high tibial osteotomy with a plating. And then thereafter we will have a talk on focal dome osteotomy, and then we will have all of you be able to perform the, so I must acknowledge some great stalwarts here, Professor Junjunwala, who many of us know, some of us don't know, has performed closing wedge high tibial osteotomies in maybe 5 or 10 or 15 minutes. He's been a master, he was a master surgeon, and deservedly became the president of Asami International as well. So I acknowledge your presence. Also Professor Agarwal, who's also a great master in high tibial osteotomy, and as are so many of you. So let's look at the scope of opening wedge high tibial osteotomy. Now we are all familiar with the fixators, but majority of ladies do not want external fixation. This is a pathologist. She has 0% passage of the mechanical axis, and her daughter's wedding is coming up in 4 months. They have been subjected to arthroscopy 2 times. They go to a big city, they do an arthroscopy, they do an MRI, and they say, you're too young for a total knee, we have to do an arthroscopy. So this picture is going on and all still today. And 3 times she had an arthroscopy with no benefit. And what you really need is a simple medial opening wedge, standard high tibial osteotomy, when you don't have to correct a large deformity like this. They're up from the bed in the second day, they start walking because the Tomofix allows you to fully weight bear if you're not too heavy, and attend to your work. And there she is in 4.5 months, her young daughter got married, she had no trouble. So it's very useful for small primary deformities, the small varus. This is the ideal indication. And Dr. Ishani has said, Professor Jijesh has said, so we can customize where we want to pass the mechanical axis. Remember, if it's an athlete that we are treating, we don't want to overcorrect into valgus. A simple rule of the thumb, if you watch Roger Federer playing tennis, now he's of course retired, but if you see these guys, they all have a little bit of varus. Sportsmen, footballers all have a little bit of varus. So if somebody wants to perform sport at a higher level, do not overcorrect, just take them to beyond neutral. So, but if they are middle-aged ladies like this, who have, mechanical axis, and they're not going to perform any high performance activities, then you can safely overcorrect them to the Fujisawa point, and they'll do really well and get good relief of pain for a long time. So let's go through the steps of this reliable surgery for mild to moderate varus. This is a lady gynecologist, and she has this mild varus deformity. So we take a point about 3.5 to 3.8 centimeters. That's what we found in the Indian population from the medial joint line, okay? And then we take a 45-degree internal rotation view to find out this superior tibiofibular joint. Now our guide wire that we pass the 2.3 mm guide wire should go just so that it gives you just enough space underneath this. Okay. And then we start so we put two guide wires like this, okay, one on top of each other because it's going to guide the shape of the saw or the osteotomy. And we start the osteotomy 5 millimeters beneath the guide wire like this. You can start with an oscillating saw or with a very sharp osteotome. And then this osteotome ends just beneath the guide wires and it just breaches the lateral cortex. The previous teaching was to stay 10 millimeters short of the lateral cortex. But then what happens is that you can end up with a fracture line going into the joint or a fracture line which is worse going down below the tibial head, the upper metaphysis. We don't want that. So after that is done, we stack the osteotomes to gently open up the osteotomy here. And before we do that, and use the graduated spreader, but before we do that, we perform the biplanar osteotomy over here. The biplanar osteotomy has many advantages. What it does is it prevents the procurvatum of the proximal fragment. Many of you are familiar with the opening wedge with the fixator. That's done beneath the tuberosity. And if you do that, the proximal fragment can toggle into procurvatum and that simulates a flexion deformity. So this will prevent the procurvatum. It will add to the fracture osteotomy surface for healing. And also you can play around and correct a little bit of the flexion deformity as well. So then you use the graduated spreader which goes in all the way so that the calculation is accurate. Then an arthrodesis spreader maintains the opening while you check with the alignment rod like this. Then you position the plate. At the upper level there are 3 holes. With the central hole you put in the guide wire. And then there are the purple spacers that prevent the plate from stressing the bone that gives rise to pain. If you don't do this step, they have pain post-operatively which you cannot explain because you've done everything right. And then after that, after you've fixed all the upper 3 screws, then what we do here is we use the non-locking screw in the combi hole and that compresses the osteotomy over here, number 1. And number 2, it pre-tensions the plate. Now this plate is made of special alloy which is not the trauma plate. It uses the titanium niobium metal, not the titanium vanadium aluminum which is used for trauma implants. So this is titanium niobium aluminum alloy which has got a better stability, better elasticity as well as extra strength. So this pre-tensions the plate and you can imagine this plate is pre-tensioned like this and it always wants to come back to its original shape. So when it wants to come back, it keeps compressing the hinge. And it sets up the elastic cycle. It's like this micro motion that we heard about in Elizardo. And even without bone grafting, then this osteotomy can heal. Then you put in the rest of the screws, you exchange this screw. And more important is not to forget to put the D screw, what's known as the D screw. Because this is the area where maximum stresses are present. And you can be rewarded with a very good correction, very good return to activity in active individuals like, medicos or sportsmen, etc. Of just a few nuances before we go to the actual hands-on workshop, which is only going to be a demo. The primary deformity, if you do it in a large varus, before you understand all the other type of, if you do this in an elderly lady, there is no problem. So, nicely we've overcorrected her. There is no problem. But only thing is that the fracture line can extend into the joint if you open a large opening wedge. And you can detect that on the table and fix it with a screw. And in the very elderly, it's no problem. Though she walks slowly, she has 0 pain 8 years after the surgery. So this is type 3. So these are the Takeuchi classifications of the hinge fractures. The type 1 is what we were worried about. Now we aim for the type 1. We aim to take the osteotomy all the way to the lateral cortex. And the type 2 is the more worrisome one that goes beneath the tibial head into the metadiaphyseal junction. This is the worrisome one. If the patient comes back to you in a couple of weeks, then you know that he's with pain, then you suspect and look for this by taking a 45-degree internal rotation view. And the type 3 goes into the joint, which you should be able to detect and prevent. Now, there are various ways of doing that. Again, here, this is, type 1, this is type 2, and this is type 3. So the aim is to stay in this zone. This is within the superior tibiofibular joint and lower at the lower level. So if your osteotomy ends here, you're going to be safe. So type 2 is downwards. This 75-year-old lady had this, moderately large deformity, and she was up and about within a few days. She's very highly educated, and she was wonderfully happy and came back with pain in 4 weeks. And when we took a proper X-ray, because she was walking full weight bearing, she got this type 2 fracture. So all you have to do sometimes is keep them non-weight bearing for a while. And she went on to heal without problems. I showed you this, the lateral cortex, and that you can intentionally create it with your osteotomy just stopping a millimeter short of breaching the cortex. There was a question about the patellofemoral joint. The classic textbook describes an oblique incision like this, but we like to take a longitudinal incision, release both the medial and the lateral patellofemoral retinaculae like this, so that you can address minimal intraarticular pathology. And then at the end of it, you can use the cautery to burn all the nerves. So it works like a neurectomy. It improves the knee joint range of motion. And what I have found, surprisingly, so this lady had large deviation before we understood the intra-articular pathologies. We performed the medial opening wedge, and we did not do a patellar retinacular release. And if you open, so this case has taught me several lessons, why we need to follow the algorithm. So this was a large deformity to start with, and what she deserved was either a focal dome or she deserved an intra-articular, but we performed a medial opening wedge. We did not perform a patellar retinacular release because she had no tenderness. And now, lo and behold, even though we've corrected her only to 54%, at the end of 4 years, she comes back to us complaining of severe pain. We first thought that the plate is impinging, so we removed the plate, but she had no relief from the pain. So if you overcorrect in a medial opening wedge, you can end up stressing the patellofemoral joint. If you overcorrect the MPTA to more than 95, you can create an ACL degeneration. So these are the reasons why it's best to only correct small deformities with the medial opening wedge. Now you can compensate for fixed flexion deformity. This is the last bit. This lady had this varus. You can see the FFD. This is the Miniachi method. It tells us that we need about 12 degrees correction. So here we found 12 degrees. So we need to perform the patellofemoral release because she has pain. She's about 15 degrees. So Professor Koshino showed us every 5 degrees of fixed flexion deformity masks and hides 1 degree of varus. So you need to add 3 degrees of correction, and she has a lateral thrust. So we can overcorrect these elderly ladies and they will do very well to, really correct. So similarly, older folks can tolerate this well because it's a good implant with bilateral 7 years after the surgery. But sometimes it's not the ideal indication if it's an intra-articular deformity. So it's best for mild varus, not for the severe deformities, as I showed you, Now, there is a lot of confusion in the literature about what to do when you find a high JLCA. Okay, when you have a large JLCA, there is a lot of confusion because they're trying to solve all problems with a single osteotomy. When they find the difference of preoperative varus valgus stress radiograph, that means it's a high JLCA. Ideally, it needs an intra-articular osteotomy. So I won't dwell upon this much, but if you were to choose a medial opening wedge, then you can subtract the varus JLCA minus valgus JLCA divided by 2. And undercorrect a little bit so as to not overcorrect. So large opening, you'll get a hinge fracture, ACL degeneration, patellofemoral problems, well described by these in 2019. So anyway, I'll wind up over here. We will have the brief demonstration. So this lady so we did not overcorrect her, took her only to 54% like this. And I have shown you this gentleman's x-rays. And if this video works, a well done medial opening wedge, just correct it to 54%. And it allows them, of course, to perform all their activities and yet retain. running in 6 months. He runs marathons. And can do whatever he wishes to do. So do not overcorrect. Okay? We do not overcorrect. That's the message with the medial opening wedge. So now we will move on to the demonstration. I will, and we will do the focal dome osteotomy. All of us get an opportunity to perform the focal dome osteotomy if they have changed the bones. So briefly in 15 minutes, we'll perform the medial opening wedge with a plate. Come, camera. So the question as we are setting up is how many of you have performed the medial opening wedge with a plate? Please. Great. Fantastic. So obviously we don't have to spend a lot of time, but this is for those of you who have not, and it's a, can you see carefully? Focus over here. भरतूंगे थोड़ा, भरतूंगे दादा. इसको नीचे कर सकते हैं थोड़ा, नीचे कर सकते हैं, नीचे करो. और थोड़ा. ये मीडियल साइड यहाँ पे, इसको यहाँ खड़ा करना, इधर करो आप, राइट टू लेफ्ट कर लो, खोल के ऐसा, क्योंकि यहाँ से ऑस्टियोटोमी करनी है. बोन दिखा, बोन दिस साइड ऑफ या एक ये थोड़ा सा निकाल. Professor, and correct me if I'm going wrong. So why are they? Can you move this there? Can you see? Can you remove this? Remove this. Remove this. A card. So we start wire से. Wire डालो इसमें. पण काढून घे. काढ. कोणाला बोलवायचं? कोणाला बोलवायचं? And may I request also Professor Srinivas Reddy also to join us on the stage. Give us a bit of a hand. So you can see this now clearly. ये सब निकालना है. ये सब यहाँ से निकालना. ये confuse हो रहा है. Zoom in करना तो. So he's created a very nice jig over here. But obviously this surgery cannot be done, unless you use the C-arm very accurately. So after the incision is taken and the patellofemoral joint is dealt with, थोड़ा सा अजून वरून खाली घेतो का? जवळ येतो का? जवळ या ना. जवळ या. इथे बघ ना. त्याचं साईडनी दिसतंय. तू वरून घ्या ना. वरून घ्या ना. अजून जवळ. देखो. Can you see? Is this all right? थोड़ा सा वरून घे. So we start at a point approximately 3.5 centimeters. So the tibial tuberosity, can you please hold? Thank you. Tibial tuberosity is a zone which ends rather distally, okay? So it's a zone about 15 to 20 millimeters long. And what we want to do is go through the osteotomy, the main osteotomy goes through the center of the tibial zone of the tibial tuberosity. And the wire that I'm inserting with the help of this jig is going, we don't have a C-arm, but we are hoping that it's going to, pass. So we are a little below the superior tibiofibular joint. So we'll go a little above. Okay. So I've exited just above the superior tibiofibular joint. One more wire. Ek aur wire, sorry, watch us. One more wire, just like this. So ideally this needs to be no, don't need this. Ideally this needs to be a 2.3 millimeter wire. Yes, sir. Yes. Great, it's a 2.3 millimeter wires because the wires perform a lot of crucial functions. Okay. What firstly it does is it acts as a guide for your osteotome or your chisel. Okay. The second thing is the wires have a predetermined depth, the length. So you can find out what is the depth of the cut. Okay. And the third thing it does is it stiffens up the proximal fragment. it stiffens up the proximal fragment and it prevents the osteotomy line from going into the joint. All right, now that this is done, now we can use the saw to make the task a little easier. ये कैसे करेंगे? इसको लूज करेंगे correction के बाद, इसको लूज करेंगे, we'll loosen it and then we'll be able to do the correction. Yes. So now a couple of important points over here. This is your osteotomy saw. There are two suggestions about this. One suggestion given by Professor Stobley, the inventor of the Tomofix system, is that you have to use a brand new saw every single time. And there is a specific saw blade that they recommend in the Synthes catalog, which is only 0.9 millimeters thick and no more than 12 to 15 millimeters wide. That's the ideal saw. It is about 55 to 60 millimeters long. If you use this, if you use a saw that's typically used in total knee replacement, it oscillates a lot and your posterior soft tissues can be in danger. Now, one of the tricks used by great surgeons in the past, and Professor Borua will attest to this, is that people would flex the knee to hopefully get the posterior soft tissues out of the way. But it is now shown by anatomical dissections that, there is a branch of the tibial artery which tethers the popliteal vessels close to the tibial surface, and flexion doesn't help. So what we do before we actually do this surgery, there is a component of the surgery in the workshop which we can't talk about unless it's the anatomical cadaveric workshop, is we perform the medial soft tissue release. Now the crucial thing to remember is the release of the superficial medial collateral ligament. Now this is going to play a role even in the next osteotomy. If you do not release the superficial MCL and you acutely open out the osteotomy, the medial joint line is going to be under greater pressure. And your patient, instead of having relief of pain, may have an exacerbation of the pain. So we release the superficial MCL en masse with the periosteum, with the pes anserinus. That's the key. Once you've done that and you have gently gotten them out of, it's no pie crusting, and we want to take the entire soft tissue mass together as a complete soft tissue mass. Once that is done, and then you also release the posterior soft tissues, you can place in a radiolucent retractor, or sometimes with your hand you can even be able to go all the way down and feel the superior tibiofibular joint. Now remember the tibia. You have another tibia? एक और अजी एक tibia है तुम्हारे पास model. If you see the tibia, okay, let's look at the tibia carefully. Can you see this? In the posterior aspect of the tibia, there is this depression, yeah? And this depression can play havoc with your radiological view on the lateral side. So if you are going to, the crucial step is to make sure the posterior cortex cut is complete. If out of fear of the posterior structures, this happens to beginning surgeons, if you don't cut the posterior cortex completely, then you can end up with a procurvata. So you need to cut it completely without damaging the posterior soft tissues. So one trick I have found is not to have the C-arm perpendicular to the limb, but the C-arm must be perpendicular to this oblique line, to this oblique osteotomy. And that shows you exactly whether the saw or the osteotome is really going behind the posterior cortex of the tibia. So you cut the here we can take the liberty for safety. Now you're cutting only the posterior 2/3 of the cortex over here and posterior 2/3 of the tibia. You're not going all the way to the anterior part. As you can see over here, we need to perform the biplanar cut of the osteotomy. Now we are almost finished the osteotomy. So before you finish it, then we perform the biplanar cut. It's at about 20-degree angle to this, and you get the whole thickness of the tibial tuberosity like this. You can use a smaller saw blade. Here, for the want of time, we will not waste our time. And what you can do is you can find out the top of the insertion of the patellar ligament with the help of a hemostat, and you can have a smaller blade, and then you can just angle it up like this and complete this cut, the biplanar cut. Once that is done, you can go ahead and finish your osteotomy. So this is almost done. This is like a type 1 hinge fracture. Once this is done, अभी इसको लूज करेंगे हम. Okay, so okay, now अभी थोड़ा सा रुको, इसको पकड़ के रखते हैं. ऑस्टियोटोम है, बेतरंज है तुम्हारे पास at a time. So one of the tricks that we use, so this is a famous instrument which is used. It's called the corticotome. You can use this if you feel more comfortable that you are not going to cut the posterior cortex. So this nib or this protuberance will protect the posterior soft tissues, and you go with this. But having completed the osteotomy, now these are the osteotomes which are popular, which are exactly the ones in the Synthes Tomofix set. These are these thin, sharp osteotomes, and we take the trouble of sharpening them before every surgery, and their calibrations. So it tells you how much to, once you've gone in till the depth, to open it, a simple, very old Eastern European trick, which the Russians, I have seen Professor Shevtsov and the great Russian surgeons stacking the osteotomes to open the osteotomy. This is a very old trick in the book, and by stacking the osteotomes, you are very gently opening without necessarily creating a fracture. You can take a third one like this, and you can, just gently stack it till they are open in this manner. So now he's opening the osteotomy edge like this. And what you can do is, if we want, this is the graduated spreader. So you close it first in the set completely. You close it completely. You make it and you make it a point to go. Again, this must go through the posterior cortex. If it only goes through the anterior cortex, pachi kariye na hammer joiye. So we go with the graduated spreader all the way till it goes to the intended surface. All the time we are looking in the lateral, okay? We don't want to go beyond this. And this has now gone all the way, let's say, for the sake of understanding. And then what we are going to do is, with the help of a screwdriver, we are going to open this graduated spreader which has got markings. So let's say, for example, we wanted to open a 8-degree. Can you do it, sir? Over here. Okay, just hold it, please. Yeah, like this. So we're just holding this part. Huh? How much is this marking? So you can see this marking, say 8, 9 or 10, like this. This is the amount we want to correct. Now what we do is, there is sufficient spreader up. So I use 2 spreaders in the theater. One is after you've opened this, then with one spreader you maintain this anteriorly, but that's not where you want the spreader to be. Then you close it, please. You keep it held open. So this is kept open temporarily with the other spreader. Then this posterior cortex is held apart by this spreader like this. Okay. The posterior cortex holds this apart very nicely. And then you insert. While this is holding, sometimes it doesn't stay there. Your associate holds this, and then you can apply this plate. At this point, we remove this. You can remove this wire. I'll hold this up. Nikaliye, sir. Drill se nikal. You can remove only the top wire if you wish, or you could remove both the wires, and that will allow you to insert the plate, very nicely. Now, at this point in time, now remember, what are we doing? We have chosen to plan. Professor GJ showed you and Dr. Ishani showed you that we planned that we want to open, let's say, only 8 millimeters. Now, you do not want to rely on the position of I'll get rid of this. Take it out. You do not want to rely on what's happening on the table. You do not want to rely on the alignment rod, because you can be fooled. If your hip is in a little flexion, if your knee is in a little bit of flexion, if there is a bump under the trochanter and there is internal rotation, if the tourniquet is very high in the thigh and your rod is not nicely aligned, all of these are going to fool you, and you will think you are overcorrecting, undercorrecting. So you stick to the plan. And therefore, in the beginning, it's always better. Thank you. So the plate that we have, so the plate has, the nomenclature of this plate is this is the horizontal section. This is screws are 1, 2, and 3. A, B, and C. And then this is the D screw. And then in the shaft portion are the 1, 2, 3, and 4. The 1 and 2 are combi holes. It comes in the thin and the thick variety or the broad variety for the large patients. You put these sleeves and then you position the plate. Now you position the plate in such a way that you make sure that your D screw is going to go into the, stay above the osteotomy. That's the key. And that's how we position the plate. So there is going to be a little bit of adjustment because the tomophic system is designed for European bones. They have only shortened it. There are certain tricks that you need to follow. One of the things that inevitably happens is this spreader pushes your plate up. And what you have to do is you have to try and align the posterior part of the plate to the posterior cortex. You don't want the plate to ride up anteriorly because the maximum forces are near the posterior cortex. So you have to juggle a little bit. Sometimes I also have to put in the spreader, maintain the same opening anteriorly, remove the spreader so that the plate goes behind. And then we use the sleeve first to lock the plate. There is a central, so what we do first practically, Aji ek sleeve che, one more. Guard wire nahi, any under so wire che any. So there is a wire sleeve, and you make sure that the positioning of the plate is such that the wire is not going to go into the joint, and that the wire is, so that your D screw is also going to be in the proximal fragment. So you do that. That's a very helpful trick. Even though the osteotomy is the difficult part of the surgery, these small things are going to help you get a good fixation. You pass in this wire. One of the things you can see is, Okay. So typically we place this in the central hole, and then we will take a drill bit, and the posterior screw is the crucial one. So when you drill for the posterior screw, you make sure in a good lateral that the screw is not coming out, as I showed you through this depression in the tibia. Through this depression in the tibia, you don't want the screw to come out here, and you will be fooled into believing that the screws are well within the bone, and you can still have the shan screw to touch mara hai. So it's touching the shan pin. So कोई बात नहीं है, स्क्रू डाल देते हैं छोटा वाला, छोटा स्क्रू डाल देते हैं. Sorry, thank you. So the key is to put the posterior screw tends to be a little और छोटा डालते हैं, सबसे छोटा दीजिए. So these are 5mm screws. They're pretty strong. So the posterior screw is the crucial one. You don't want it to exit from the posterior cortex, and that's where you want to take a lot of care. And you don't want the plate to impinge upon the near the joint capsule. So actually the position of the osteotomy is also determined by this. So first you position the plate on the patient's limb and make sure that your osteotomy is going to be sufficiently beneath the D hole. So now we will put one more screw. We will drill. क्या हो रहा है? ये टच मार रहा है इसको. कोई बात नहीं. इसको निकाल. T handle. ये निकाल इसको. पीछे. करो. आता नहीं, स्मॉल है स्क्रू, स्मॉल निकालो पीछे नहीं. ओके, अभी वायर निकालते हैं. बाहर निकालते हैं. So now we will put 2 screws at the top and we'll show you the crucial step of the golden screw, and we will not spend more time on this. Wire, drill the wire, drill the. So actually, the stomofix plating system has ruled, the industry for the last 20 years. But I'll have you know that the Japanese have designed different set of plates which have better contour, because the Tomofix is designed for both right and the left. But the Japanese have designed plates which are separate for right and left lower limbs. Screws में डाल देते हैं, डाल उसको. Forget it. इसको लेते हैं, स्क्रू ड्राइवर मैनुअल लेते हैं. सर आप करो स्क्रू ड्राइवर दीजिए मैनुअल. Here. So they've designed for both the right and the left separately, and what that does is it allows better contouring. Now one of the tricks I want to show you as we are performing this simple task of putting in the screw is that the plate sits flush on the bone in such a way that your screws want to exit posteriorly. So very frequently the trick I have to employ is to keep the plate offset away from the bone so that the screws go more laterally and get a better purchase all the way into the lateral compartment. So अभी non-locking screw है, हाँ दीजिए. Okay, so you lock this. This is done. This part is done, and we are still holding with the arthrodesis spreader at the right angle. Now the crucial step is to pass the golden screw or the non-locking screw like this. In the combi hole at the lower part is the place for the non-locking screw, and you hold this, and you'll come to know why this is. You angulate it in such a way that it doesn't impinge on the next locking screw, or in this direction. Yellow screw, non-locking. Yes. लंबा है इससे लंबा है. Okay, so this one here isn't very long, but the key, now this is the interesting part. At this stage, you want the music in the operation theater to stop. Okay. So as it comes close to the plate, if you observe carefully, as it comes close, the screw should be sufficiently long, so it has to go beyond the lateral cortex. When it does that, it does two things. You will see that it compresses the hinge over here, and the second thing is, beyond the point, it will also bend the plate. And this is the crucial step of the surgery. It's building in pre-tension into the system, and it's also compressing the hinge. Now the thing is, we don't want to overdo it. You see what's happening here? The distal fragment is shifting. Okay, we don't want it to shift. We just want to give it enough pressure to compress the hinge. We don't want to translate it medially. That's something we don't want, because कैसा निकालना? नहीं निकलते, रहो दे. Okay, so then at the end of it, so you want to pass one more screw. Now that the arthrodesis spreader can come out, and we can pass the remaining screws. Yeah, yes sir. The arthrodesis spreader can come out, and now we can pass the remaining screws. The important in this golden screw is to just do the right amount. It's like cooking. Don't overdo it. Focus on what you're doing. Have one person designed to look at what's happening to the gap. Have one person looking at the C-arm to see what's happening at the level of the joint. You don't want your gap to reduce a lot, and you don't want the distal fragment to shift. If you take this care, then you don't need to use hinge protection wires in the medial opening wedge. This has become all the rage. Everybody talks about using hinge protection wires, plates, screws, and everything. If you do this step carefully, you will not have problems with hinge fractures in the medial opening wedge. Now remember, in the beginning of your career in high tibial osteotomy, if there's one osteotomy that's going to serve you the most, this will be the one for small to medium deformities. And if you perform these steps carefully, you will be rewarded with a patient who has very little pain post-operatively, can mobilize early. And now what we are going to do is, of course, then we're going to fill up the screws. We are going to remove the blue or the golden screw, the non-locking screw, and we're going to put all the locking screws. Previously, they used to say use only the cell drill screws, single cortex, but it's better to put both, especially in thin, lean patients. And if you've used this purple screw, spacer screw here, remove that. If the plate is away from the bone, then it's not going to, create pressure and give rise to postoperative pain. And the last step of the surgery that I would do is I will suture back the MCL along with that onto the plate. And you check for mediolateral laxity. Of all the people, Robert Laprade has spoken about this, and he has carefully done anatomical dissections, and he has spoken about the need for retightening the MCL. So that's something you need to look into while we are performing this. So I think we'll wind up now. So that brings to an end this demonstration of the medial opening wedge. I thank you all very much. Now we're going to go to a brief talk. Yes. Brief talk on focal dome osteotomy. Then all of you get to do the focal dome. Yes, sir. Yes, a good question. The time when we were opening large wedges with the medial opening wedge, we would put in graft. You can use the Kronos Synthes or any beta TCP or iliac crest bone graft if you have the ability or the desire. There are benefits of putting in grafts. It reduces the hematoma. Yes, sir. Correct. The beta TCP wedges are available. Yes, yes. It reduces the hematoma. It increases the cost. If you're going to do iliac crest, grafting is going to increase morbidity. Yes, this is a... That's the reason why we don't open up a large wedge. That's one of the reasons why we don't open up a large wedge. And that's one of the reasons when we used to do a closing wedge osteotomy and remove a wedge, that time you're fiddling around posterior to the patellar ligament, there would be, patellar ligament fibrosis. So these are some of the things we do take care.
Milind, can I ask a question?
Yes. Not cut, sir. The entire soft tissue mass of the pes anserinus and the superficial MCL as a single layer has been released subperiosteally and is now sutured back to the plate. This step is not described by many people, but you judge the postoperative laxity and opening up, and you can take this step if you feel that it has opened up too much. But if you don't release it, you're going to tighten the medial joint and increase the pain. Yes, sir.
Milind, excellent presentation.
Yes, Professor.
I have modified some technique in this point.
Please tell us.
As we are calculating the digital planning,
yes,
the exact degree. So I found that after removal of the distractor, there is a possibility you might lose the correction. Yes. So I modified by fixing cross K wires from the lateral side to the medial, and lock it. And then I don't require distractor.
Very nice.
Yeah, so that locks the correction. And
That's
then I just put a plate.
Great idea.
And second thing, most of the complications which can occur with this osteotomy, that extension of osteotomy going into the joint. So, which is very common complication, and then it will be a difficulty. So, what I do, I put a subarticular, K wire, guide wire from lateral side to the medial side to prevent the osteotomy to going inside the joint. So, by putting the wire inside beforehand, you prevent the extension of the osteotomy into the joint. So, these are the few things.
Yes, of course.
Proximally, just below the joint line. Parallel to the joint line, wire before going for osteotomy. One wire parallel to the joint line from lateral to medial, which prevents the extension of osteotomy. you do before that, before starting the osteotomy, so that the osteotomy should not extend inside the joint.
Again, लवकर करणं वेळ लागतोय, पर टाइमपास होतो.
No, they are different. This is joint parallel joint. Parallel joint.
So now we come to the Elizabeth or the principal deformity correction. That's the focal dome osteotomy. You will get to do it here. ये टेबल के ऊपर चेंज करके दो ना, ये आखिरी वाला बाकी है. So the focal dome osteotomy is a very powerful osteotomy for various reasons. I showed you this with a large varus, no intra-articular, with the sagittal axial rotational. It's where it's indicated. Now see this. Joint, and based on that, what you can practically do is pass in a wire from anterior to posterior, place a Rancho cube, place a jig around that wire, and then subtend an arc distally. Now the important thing about this arc of this osteotomy is that it must go up above the superficial MCL. Okay, so the Mackay is wonderful because early healing and simple hardware you can use. There's very little space for better hardware fixation, whereas with the focal dome you have lots of space and it allows you lateral translation. And more compression for healing. And those of you who follow and read, very surprisingly, I found this from Nassim Taleb's, one of his videos. He talks about convexity of options and concavity of your behavior in the financial markets and in life. And he says that the convex options are the better ones. And the concave options like the Mackay dome is the sad one. So anyway, that's, so the Elizarov fixator has a great role in this, especially. This is an orthopedic surgeon, large deviation. And you note over here, this is the focal dome with the Elizarov. This very small one cortex translation of the distal fragment. And on the lateral view, a one cortex translation posteriorly. This is not an obligate posterior translation. It's an external rotation of the distal fragment, which is seen as a posterior translation. And this external rotation is the key in shifting the mechanical axis lateral. Instead of that, if you were to just open a large angle, then your ankle joint will have a large valgus opening. So the shift achieves the mechanical axis translation without excessive angulation. That's the key. And that's what you do. So now where do we end this correction? I'll be brief about this. One of the ways in which we decide with the Elizarov focal dome or with any external fixator is you can correct till the lateral thrust is eliminated, not necessarily on a radiological angle or a point like the Fujisawa point. As soon as the lateral thrust is eliminated, when you watch him walking before surgery, he has this lateral thrust, okay, as Professor Jijesh also showed you. So when we do the surgery, we train them, we out-toe, short stride, etc. I'll talk about this later when time permits. And this is how we we stop the correction. And you can see the tiny external rotation and there's no more lateral thrust. As soon as the lateral thrust is eliminated, we stop the correction. And that's the beauty about the Elizarov, that you can, achieve this and give them long-term results. So we've gone through this. Remember this. This is one of the joys of using external fixation, which you cannot. why not Elizaro? So recently in India, there has been a resurgence of the Elizaro for some things, and for some things people are reluctant. People are worried about middle-aged ladies and that it requires more expertise. But the focal dome has many advantages, all these advantages, several of them, at least 15 advantages, as I have shown you. You can correct very large deformities like this. There's no loss of bony contact. All these advantages are there. You can do it in a person who has an amputation and medial compartment arthritis. Here it can allow full weight bearing. You can perform bilateral at the same time. That's a great advantage even in middle-aged ladies. And you can just add the patellofemoral release like I told you. You can see this large internal rotation. You can correct that in this person, which gives them, result for 15 years like this. They can, they really do well with this osteotomy without any problems, even though you overcorrect some of the people who are not very active. And you can, you see this, some people present with complex problems. This lady has some shortening. She has a malunion in the lower tibia. On the right side, we do the medial opening wedge. And then in the left side, we perform this mild translation and correction of the length also at the lower level to give the customized results. So that's the advantage. This is a professor of medicine. He has this severe varus internal rotation and shortening. Nothing better than the Elizaro or its variants like this to perform lengthening derotation to give them the desired result. No need for a replacement. You can see the lateral translation. That's the key here. So this is a wonderful surgery. This patient has got a long leg arthritis due to polio. On the other side, he's 4 centimeters longer. If you take him into valgus, he'll become longer. So instead of that, we resect 4 centimeters, we shorten and give him, valgus. He's free from pain for 28 years now running. And for those who don't want the fixator, you can perform the fixator assisted plating like these patients. We can use a long X-ray like this, to make sure the alignment is correct. The focal dome is performed with the minimum Elizaro with a big X-ray film. Or Mangal has a very nice plastic goniometer that he uses to help you correct on a small film what's the amount of correction. And then you can do these, you can do a fixator assisted plating to allow this person to, this is actually the steps of the surgery for fixator assisted plating. As we are setting up now, you can watch this lady. There is no instability. There's a large varus. So now we'll be going on to the actual surgery. You can see this large varus. So we start with a fibulectomy. Please do not stop at a proximal fibular osteotomy if you want long-term results. This is just the beginning. You do the this is a must. That's an advantage and a disadvantage. Then the incision. You do the lateral retinacular, medial retinacular releases like this. Medial and lateral side. You cauterize the nerve endings. You open up the joint. You can harvest the osteophytes. You see the range of motion has improved in this patient. And then you can remove some osteophytes. You can remove the osteophytes from the femoral side. You can do a subvastus approach and use the osteophytes as grafts. What Dr. Junjunwala said, these osteophytes have a tremendous osteogenic potential. So this is the en masse release of the medial soft tissues. Okay? And especially on the medial side, this is the superficial MCL insertion here. Then we temporarily put in the Elizaro, 2 pins in the center. You keep it free posteriorly. And then proximally, like this, you drill the anterior Schanz pin. You fix this with the help of Rancho cubes. And you keep it open medially with a 5/8 ring. And this is a curved jig. You can use it freehand or a curved jig to create the curved osteotomy. And then these thin osteotomes to complete the osteotomy. You are just distal to the tibial tuberosity in the center. And on the medial side, you are going up above the insertion of the superficial MCL. The osteotomy is above the insertion. That is why it doesn't stretch it so much. And then the posterior cortex is cut very carefully. You don't want to create comminution of the posterior cortex. That can give rise to procurvatum. No comminution. So you do it slowly. Use drill wires, drill bits, thin osteotomes, and then you complete the osteotomy. And then the key is you do this shift This is the shift. This is this lateral translation, and yet there's an excellent bony contact. So there are two ways of doing this surgery, theoretically and practically. The great Maurizio Catani taught me 33 years ago how to do it practically. You manually shift it. If you rely on the hinges to achieve the translation, you'll be left struggling in the OR for several hours. So you've done this, you've achieved your correction, and then just put in a plate. Remove the fixator at the end of surgery. You don't want to translate this. You don't need the golden screw here. So as I said again, what we are going to do is this is a very powerful osteotomy, and then at the end of it, but the important thing for those of you who know how to use the Ilizarov fixator well, this is a great osteotomy to perform. And this is going to give your patients a very long-term result if you combine the newer modalities of learning that we have along with this. So let's get on to the workshop now. All of you, you have the varus tibia. So we've created a frame like this. You can see there are only two rings. Ideally, you need a third ring at the bottom. Okay, I'll describe this, but we won't do it for shortage of time. Now, may I request before I have so many bright young, there's Professor Aradhana, there's Dr. Goda Siri, there is Dr. Amar. Please help Professor Jijesh also, please help them on the tables. Professor Srinivas. And so many of you are great experts in the Ilizarov. Please help your colleagues. So distally, we are going to place in, you can pass in a wire parallel to and just above the ankle. And you can pass in 1/2 pin medial to the tibialis anterior tendon. And you have a distal block. And in the center, you have this ring with 2 half pins, which is very useful for thick patients, thick-set patients. If it's a thin, lean patient, only 1/2 pin is enough. That's the distal block. Now, the proximal block, the key is to have the ring mimicking the angle of the joint line and 2 half pins. So you can start practically by placing a wire parallel to the knee joint line, checking under the C-arm, attaching the ring to this wire that allows you to remain true or parallel to the joint line. And then you're going to pass in 2 half pins. One goes at the Gerdy's tubercle from anterolateral to posteromedial. That's above the ring. And the second half pin is the medial face half pin that goes medial to the tibial tuberosity. So 1 wire and 2 half pins makes it an extremely strong construct. Once you've done this, you attach the second ring. Now there are 2-3 ways of doing this. You can attach the multiplane hinges as we have done. A couple of tricks. On your table, you're likely to find rings of the same size. When you connect 2 rings of the same size with the multiplane hinges, then you also need to use the connection plates, like the first surgery was elegantly shown by Professor Sudnetsin. You need to use a lot of these components, including the connection plates. So if you have a larger and a smaller ring, it becomes easy with the multiplane hinges. It's very difficult to perform this lateral translation without the help of multiplane hinges. If you take a great amount of care, you could do this by placing the distal block, especially the distal ring, slightly medially deviated away, and you could place, just by straight rods, you can achieve the right, but it requires a great amount of skill. The multiplane hinges are your friends, and it helps you to perform the surgery. So this is what I would recommend. You start by attaching these 2 rings and just have the multiplane hinges ready. We'll show you how to make them. I think in the first workshop, they showed you how to make the multiplane hinges. Ideally, so I'm told by our President Rajat that those of you who are keen on doing this workshop can stay on. And those who wish to break for lunch are welcome to do that. On the way back, they can complete the assembly. Otherwise, we are free to go on those who wish. Lunch is ready, it's served. So I'll just show you briefly how to perform the ideal single plane hinge, the multi-plane hinge. You need, these are the threaded rods. So you can start working on it. As you listen, you can start working on attaching the two rings like this. This is the a one-hole female attached to a threaded rod. You can attach a one-hole male hinge over here, and you can attach you can take another use a long bolt. Nut, please. Nut. Lamba, medium bolt. Long bolt. It's making lots of noises. So this is, can you see it? This is the multiplane hinge. You make sure that they are finger tight when you attach it, and you do not tighten them. Put the two threaded rods. One member of the team can make 4 of these multiplane hinges. One person holds, may I recommend?
Guys, can we have your attention please for 2 minutes? The people who are staying back, some helpful tips that will make the workshop easier. I just want to give you a heads up. We work in a bit of a flow, so we'll give you instructions as we go.
So, one person holds, you create the rings. One group of people make the 4 multiplane hinges like this, please. Make the 4 multiplane hinges. Now, there are advantages to using the ready-made multiplane hinges like these. Can you show? Okay, so this is a pre-constructed hinge, both female. This is one with one male and one female. The way I like to do it, and the one that has the greatest advantage, is to use a one-hole female, and then you can use 2 one-hole male hinges of the thin profile. What this does, so one of you please start creating the 4 multiplane hinges. One of you assemble the rings. You have a lot of help. There are a lot of highly experienced surgeons here who have done dozens, if not hundreds of Ilizaros. You create the 4 multiplane hinges. Yes. So the one female goes to the threaded rod. Capricious. And you can start by placing a wire first parallel to the joint. The first wire is just at the level of the top of the fibular head. Just at the top of the fibular head. A little below that. Through the thickness of the fibular head. Why? So that the ring is attached to it, distal to that wire, and then you pass the half pin through the Gerdy's tubercle. That gives the maximum purchase. Because the Gerdy's tubercle is thick, and then that half pin tends to come posterior medially here, where there is again a lot of thick bone. So that gives very good fixation. And then the second half pin is distal to the ring. So these 2 half pins make a perpendicular. So any time in a block of rings, if you have wires that make a perpendicular or at right angles, you will have increased stability in all planes. In a single ring, because you don't want to have 2 rings, the way to achieve the stability is to have these half pins making a right angle or as close to a right angle as possible. The distal ring can be, you choose, you can put 2 half pins today, don't bother about the ankle fixation.
Okay. So some members of the team can focus on what's going on here. As I said, the tasks that we have, one person can put the wires and the half pins. Now there are two ways of putting in the half pins. One is you can put them freehand with due respect to the anatomy and then attach either with the help of hinges or directly to the rings. If you have that expertise, I also request Professor Praful Herode to help the people. He's also a big expert. He's a professor and head of Department of Orthopedics at a big medical college in Maharashtra. You pass the wire, attach the ring, and you can put the Rancho cubes. You can attach the Rancho cubes and use the sleeves to drill through that. So it saves you on time. One above, one below, and in the distal ring like this.
ये बीच में आ गया सर पूरा अलग से हेलो
One group of people focus on attaching these two rings. One group of people, at least two people, make 4 multiplane hinges. Be on the ready. So you can do this exercise quickly. The key here, remember, the key here is to be able to achieve valgus correction and be able to externally rotate slightly. That's goal number 1. Goal number 2 is later in the post-operative phase, if you need better correction, you should be able to translate. If you are not happy with the amount of translation, because these are the glitches. You remember, even when the Chandrayaan goes, or before that when the Soyuz goes to the moon, or before that when the Apollo goes to the moon, even though they have a program, they keep tracking it and they keep making changes. So in the post-operative phase, if you find that the correction is not good or the lateral translation is not good, you should have the ability to make simple translations. So the multiplane hinge is a great tool to achieve lateral translation also in the post-operative phase. So when you do that, the crucial thing to remember is, if you show me a single plane hinge, एक single plane hinge बना के दो. So I'm talking as you are doing the exercise. I hope people are making the multiplane hinges. Single plane, not this. Here, one male, one female. Here, stop. And then a whole washer meter. There are washer meter. Wrong. Professor Suhas is here. Please make use of his expertise. He is one of the most experienced Elizaro surgeons in Mumbai, non-stop for the last so many years, and has wonderful tricks up his sleeve. So please make use of his vast experience. Professor Bhola, Dr. Bhola and Professor Mohit Dhingra are here. They are great experts. And may I request Dr. James Kouris, Dr. Akrut Modi, Dr. Neerav to help out your friends on other tables. Find out what they are doing about the multiplane hinges. So as we are doing this,
Yeah, ladies and gentlemen, so I'm just demonstrating a very simple step in the entire procedure, which is making a, so the nebulizer kind enough to have given us an already ready-made hinge, which is this one, okay? So this is the ready-made one. But in case you don't have a ready-made one, how do you make a uniplanar simple hinge? What you need is a male post and a female post. You put the holes together. I'm going to pass this through it, pass the bolt through it, and then put a washer. And now what we have is a, can everyone see? What we have is a uniplanar hinge, okay? And here, can I please get a strut? Strut. So now I'm just adding this. So in the female component, in the female part, you just add in the strut, okay? So now with this, we have made a uniplane hinge, okay?
May I request Shamshul to help out the folks? Don't miss out on, he is a fantastic surgeon and our secretary. So Shamshul will also solve your queries. He'll tell you some tricks. He's a fabulous surgeon. And maybe Professor Ghassan Salame also. He's invented a lot of components of the Elizarov apparatus. So you can teach them a few tricks, sir. Thank you. Thank you.
I would just like to say that as we go through this entire process, you will learn things by and by. If there are any questions, please feel free to ask us.
May I also request Professor Satish Nesri to also help out folks. He is a fantastic orthopedic surgeon and extremely good at Elizarov. He runs, I think, the very first course in India as a recognized, postgraduate teaching program, post-MS teaching program in the Elizarov. And he has now recently got a patent in his name. So Satish, please circulate and spread the goodness. Yeah. I'll tell you. Yeah. There's an empty table at the center. If any of the tables are very crowded, one or two of you can shift and get some hands on. Empty table in the center.
So one of the questions from the audience, which is the most common one, is how do you make a multiplane hinge? Okay, so a multiplane hinge can be made with either 2 female, 1 male component or 2 male and 1 female components. So if you can, I'll deconstruct it for you. If you just see this, आप please यहाँ focus करेंगे. Yeah. So in this construct, I'm showing you here. Okay, this one. Thank you. We've got a great camera team, so we are able to see this properly. If you can see here, this is the male post. This is another male post. A male post connected to a male post, connected to a female post. You connect everything with the bolts and the nuts. But now this is how it's arranged. So now I already have one here. Can you please show it here down, please? I've made one here, okay? So there are different ways in which you can get it done. No problem. So right, so here's what we have. I need the thinner profile one, thin profile. So please make sure that you have the thin profile posts. Thank you.
There's a table in which you can shift in the center. There are less folks here.
Yeah. Can everyone see? So yeah, I'm just showing you where you approximate the female and the male post, pass a bolt through it, connect it with a nut, need another nut. This one's not, yeah. Okay, so that's step number 1. The next step is take another male post. Yeah, thank you. Take another male post and then you can pass it through this and then, thank you so much. Yeah, great. I hope everything is clear. Pass it through this here. Okay, and now wherever you, sorry, so this was the female one, we need another male one. Thank you. Yeah. So essentially, you got to keep an open mind. Depending on where you're working on the fixator, you can again use 2 females and 1, or you can use this, where now I'll pass this here, fix it up. I'm connecting the male to the male post. Alright. And now, depending on where you're working on the fixator, can you please come here? I'm just showing you what we can do with this. Now, this is how you practically attach it. Now that your hinge is made over here, this is your multiplane hinge. I'll put the male through the ring and then attach it. Okay, attach it here. Alright, so this is the way your multiplane hinge is now attached to the ring. Now just take your strut, okay, take your strut, pass it through the female post, whatever is the appropriate size. I think this may not go in this. Can I get another strut, please? Yeah. Thank you. Yeah, so there you go. Now you've attached the strut, okay, to the multiplane hinge. Initially, you keep all the components very loose. You keep all the post connections very loose. Once you have the desired angle, once, see now, for example, now I'm tightening it up. First, you tighten the connection. Once you see that the strut is parallel, okay. I'll wait for us to get a good view. Thank you so much. So thank you, Sushant, for covering this. So once we have this, okay, what I'm doing is initially the connections are loose. Initially the connections are loose. Now you see my strut is in a desired position. If you can show it from the top, Sushant. It's not easy for them as well to demonstrate this, so to capture this. So yeah, perfect. So now you see that both my struts are parallel. Both these struts are parallel. This is the perfect position. Now I will go ahead and tighten the main connection to the ring. I've tightened the main connection to the ring. Then I'll start tightening every other connection in the hinge. Okay? Started tightening every other connection in the hinge. Yeah. Thank you. Thank you so much. Yeah. Done. Perfect. And that's how now this is fixed. Now, actually what's happened is the strut is a little short. I'm going to get a longer strut. Yes. Yeah. So you just adjust the strut. There's a bit of a size mismatch between the holes and the struts. Yeah. So the essence is basically that you need to, I showed you how to connect this, okay? Now we'll adjust. Now it's parallel. Now what you need to do is make sure that the strut goes in one of the holes here, which is parallel, here in the proximal ring. Okay, it's gone in the proximal ring, and then you attach it to the distal ring by making adjustments in your hinge. Okay, see this? Making adjustments in the hinge. Thank you. Are there any doubts? Please feel free to raise your hands and ask. Yes. Yes, sir. So I can't hear you. Sorry.
please explain again?
Yes, sir.
Yeah, can you please explain again how this parallel thing is working?
So, I still can't hear you, sir. Sorry, I'll come there. Yeah, tell me. Correct. Correct.
Now you are making every rod looking parallel to that rod. So that rod becomes the index.
Yes. Now, in this case, I was giving you an example of how to make the multiplane hinge here. Right. So now, what sir's question is, which is the reference rod and what do you need? So you essentially need to make all your, the struts need to be parallel to the limb that you're going to be attaching everything to. So it's not necessarily per se only to the other struts, but also to the limb. So if I can show you, do we have another? आप ऊपर से ले सकते हैं? अच्छा वरतून दाखव. I'll take this out. Yeah. For a second, yeah. Varathun dakhव. Yeah. So this one's loose right now, but when we attach this, so let me once the process is done, let me detach it and show you like this so that you'll see that it's parallel to each other as well as to the limb. So there's no each becomes a reference for the other, but the main thing is it's parallel to the entire limb. Does that answer your question? Yes. Correct. Yes, sir. We are keeping the hinges proximally. Correct. Yes. Yes, sir. The rod should be parallel to each other. Struts are parallel to each other as well as to the limb, so that we get a neat construct. The ring also, the ring will be perpendicular. So depending on whatever is the deformity, that will be the case, and the struts will be parallel. Yes. So can someone? Yes. Thank you. Yeah. Yes. Sir, on the mic, Diana. Thank you.
So the proximal ring is. Hello.
हाँ, इस केस में वो perfectly parallel.
हाँ कोई.
But yeah, you want.
So any particular thing regarding the placement of the pins, like these pins should be above the tuberosity, right?
So you'll be
these two pins will be above the tuberosity, one near the joint and the other near the
correct. One near, so a little bit here. The one of the things here is that we're also doing it on a saw bone, but in live surgery, will be anterolateral just saving the tuberosity, and also then you'll be coming in from the anteromedial side.
Okay.
So you can be slightly. We are in this case will be slightly above, closer to the joint. Yeah.
So first the reference wire needs to be passed parallel to the joint, then put the ring on that wire and then pass two pins. Yeah. So the proximal ring will hold one wire and two pins.
Yes.
Yeah, and then these connections
yes.
Needs to be.
First we have to apply the ring, then connect with the
First we put in the pins and the wires, and then we connect the ring to the pins and the wires. So first is we put in the pins ऊपर नीचे सारे. सो एक है एंटेरोलैटरल, ये एंटेरोमीडियल, ये नीचे जो है वो एंटेरोमीडियल फेस पे शाफ्ट में, ये हमारा हो गया. उसके बाद में वी विल बी अटैचिंग द रिंग्स टू ईच अदर. कनेक्ट द रिंग्स यहाँ से, पुट अ रिंग हियर, पुट अ रिंग हियर. देन यू स्टार्ट पुटिंग इन द स्टड्स इन बिटवीन देम, एंड स्टड का एंगल बराबर करने के लिए वी विल पुट इन द for the correct angle, then we use either, if it goes straight away, perfect, नहीं तो uniplane hinge, नहीं तो multiplane hinge. Okay. Please feel free to ask questions if there are any doubts. Everyone will be happy to help you out here. Thank you. Thank you. Yes, the osteotomy will be there. Yes. Yes. He will teach you about this properly. Yes, so that part is coming up. So right now about the questions about the osteotomy we'll be taking up. Let's first put in both the rings in the proximal segment. I'll be coming to each table. Please let me know if there are any doubts.
This is medial side. So ये भी ठीक है ना, अच्छा है ना आपका. It's above. This is the lateral cortex is more vertical. The medial cortex is more sloping. On the medial side, you want only thing you want to take care. You don't want this to go. Sorry, you've done this well. You don't want this to go very close into the half pins. That's all. Here, this you're fine. Somebody was asking why pre-drill. By pre-drilling, you're not creating comminution of the posterior cortex, है ना?
अगर ये इलीजरो से भी करना है सर, तो भी ये खोल के और सारा वो वाला रिलीज कर दें.
Sir, you can do it without opening at all. You can do it percutaneously. But then the worry, we did for many years like that, till we understood. Because what we were doing, because the edge of the osteotomy is above the superficial MCL, so even when you do it percutaneously without formally releasing it, it's still not stretching it too much. That's the reason. But if your osteotomy is below the insertion of the superficial MCL, or if you are doing an opening wedge without properly releasing it, then it may tighten.
It's better. हर एक को जब भी इससे भी कर रहे हैं osteotomy, तो रिलीज कर दो ओपन. तो पेटेला को भी आसपास से सारा.
Patellofemoral tenderness है तो उसको भी कर लो.
MCL की लेंथ नहीं हो सकती वैसे बिना रिलीज किए हुए. ग्रेजुअली अपने करेक्शन कर रहे हैं तो MCL की लेंथ नहीं हो सकती.
Gradual correction corrects. If the dome osteotomy, the MCL is not getting stretched too badly.
STO.
Which STO?
No,
Dome. The osteotomy shape is? This is the dome. This is the focal dome shape.
Above MCL.
No,
then gradual
is it not stretching the MCL, what you are saying? Won't it stretch if you do the angular correction?
So now what you do is, Dr. Srinivas will show you how you correct it. This is the medial side. This is the lateral side. Now what he will show you, he'll need a pair of hands to help. You translate this and then attach the multiplane. Is this complete the osteotomy with the osteotomy? It's not yet completed. Complete karo. Posterior cortex leo, drill hole leo, complete karo. Drill hole leo.
No, it should be a little bit like this.
on the lateral side it doesn't matter. On the lateral side it doesn't matter. You complete it. Please, guys, do it. One of you slowly. Aram se karo. First, pre-drill the posterior cortex. I missed out on our local Elizaro man here. Wilfred is here. Please make use of his, suggestions on your table, please. He is 20 plus years with the Elizaro, so don't miss out. So that's communication. That's communication. That's communication. And then you don't know what's going to hit you. Post-operatively, patient will get good correction in the coronal plane, and then he'll complain bitterly of pain, and then you will find out, oh, to procervatum mein chala gaya because of posterior comminution. So pre-drill. So if the camera is here, how many of you are starting on the osteotomy? How many of you are starting on the osteotomy? Please start. Ideally, I would recommend that you start with drilling with wires. Freehand as a curved shape. I also welcome Lieutenant Colonel Rajiv Kaul. He's here. So please make use of his expertise. I need a couple of volunteers here, please. Thanks.
Hello.
Supra.
Hello.
Dr. Subramaniam Gandhi from
Hello.
Chennai. I need one or two more volunteers to help over here. Yes, Professor Mohit, thank you. We only have 5 minutes. Professor Teplenki is here. He's going to start the hip osteotomy workshop. Please make use of this. He's the world's greatest authority on hip osteotomies. Please don't miss out. Finish this in 5 minutes. So we're going to take only 5 minutes, please. No, chance pe nahi. Drill bit le lo. Just use the drill bit. Yeah.
Okay, so we are doing the osteotomy. Now you can do it freehand.
So can you bring this down? Can you bring this whole assembly down? Loosen that. More down. Let's get this boy down. The camera will work well. Yeah.
So when you do the osteotomy freehand, camera, you can do this freehand or with the help of a jig. The lateral, you can do this. Zoom in.
Can we have everyone's kind attention here? We are doing the osteotomy now.
So you can make the whole of the lateral cortex first.
You can make the whole of the medial cortex first.
Okay? Yes, so you can put in a एक chance pin ले लेते हैं with the threaded with the trocar tip. Probably the instrument also coming, but we don't have. Yeah. There's no right now we are going to be short of time, so I'm going to show you how to do it freehand. Yeah. Okay. You drill this, you put it manually. This is the Cora. Okay.
Can we have Priyank from Nebula up here? Priyank from Nebula.
Yeah. खाना खाने जा रहा हूँ. The long rancho cube. You insert. So you insert. 4 hole. नहीं तो इसका छोटा threaded rod ले. One hole hinge and छोटा threaded rod ले. You can take threaded rod, small threaded rod. ये भी चलेगा. Small threaded rod please. With इसके अंदर डाल. एक साइड पे एक फीमेल लगा. Okay, so you want to create your own jig. You can create your own jig like this. What you do is you can one whole female like this. No, like this. You put it here. You can, this goes around, okay, here like this, and then you can curve it. If you have the right sized, if the smallest threaded rod if you have, or if you have a 4-hole rancho cube. 4-hole male rancho cube. So if you can attach, somehow if you manage to have the components and attach a 4-hole rancho cube like this, okay, in any way, and you drill holes in a circular fashion, okay? So that's the way to do it. You can rustle up and do this jugaad, or you can do it with your hand with the drill. So with the drill bit, what you can do is freehand. You can try and create a small arc. With the maximum convexity. So it's curved. So you need to control this. घे ना इथे घे ना बोन मध्ये घे ना वरतून घे ना. Okay, so this is medial side, this is lateral side. What I did was I first created the hole parallel to the lateral cortex like this. Okay, now remember, the thickness of the tibia, the midpoint of the tibia over here is somewhere a centimeter medial to the crest. So that's the lowest part of the convexity of your drill hole that you make. It's not the crest. The crest is not in the center because the lateral cortex is vertical. So it's 1 centimeter medial. So the lowest hole is at 1 centimeter medial to the crest, and then the rest of the holes medially go a little more proximally. Okay? They go a little more proximally like this. Yeah?
And all the way we are, sir, infratubercular.
All the way you are infratubercular. Now what's happening? This is the medial side. The superficial MCL inserts 6.5 centimeters distal to the medial joint line. So your upper extent of the osteotomy is above that. And now you complete with the help of your drill, like this you make, and then you disconnect these, you start loosening these connections. And with a small osteotomy you connect the drill hole, small osteotomy. How are you guys doing? Have you reached the drill hole stage? Please remember, we have to vacate it for Professor Teplenki. Don't let us take his time. You have 5 minutes max now. Disconnect. Small osteotomy, small osteotomy. Okay. Okay, so you can complete this. Now you can complete this very carefully. You need about, see, the ideal osteotomy is about 6.25 millimeters wide or maximum 10 mm wide. Okay. So if you have done so you make it a point to connect the anterior holes. Then you make it a point to go step by step because you don't want to make combination. So it's a bit of an art how to make the curved osteotomy. Okay. So you made the drill holes on the lateral cortex. Even on the lateral side, it's going up a little bit. Okay. Even on the medial side, it's going up a little bit. So 6.25 to 10 mm thickness is the key. So you want to go slow for the posterior cortex. We don't have a thin osteotome here. So we are almost. No, sir, we completely break it. It's an osteotomy. Why? It's not osteoclasis.
6 to 10 mm gap between two.
No. Now we loosen this. See, this is a saw bone. It's a practical problem. So this is medial, this is lateral. Isko loose kiye. Okay. This is loosened. Don't worry about the gap now. This is practical. So now the key here is इसको हमें ये थोड़ा सा इसको निकाल देते हैं. Yeah. It's so the what it looks like. See, we have man. बस अभी लगा दो. Yes. See, but you can see what's happening is that it has got a lot of bony contact, 60 to 80% bony contact. This lateral translation, you can do a little less. You can do a little less. You have less valgus. Abhi compress. Abhi now, the surgeon holds this correction, and the assistant applies a very good assistant applies the multiplane hinges. Abhi multiplane lagao. So now see what has happened. You don't want it to go into procurvatum, recurvatum, and you can correct it. And we have done this correction. Okay, abhi lagaiye. Now you apply. Can you see over here? One cortex. Remember the amount of translation of lateral cortex is. Lateral translation is a single cortex translation. Single cortex. External rotation किया ना ये देखो ना ये external rotation हो गया ना. You see this? This was lined up here. ये पहले ऐसा था. इसको external rotate किया है. So posterior lateral X-ray में तुमको ये थोड़ा पीछे दिखेगा. थोड़ा सा किया है. Yes sir. This is a fragment. And it can, or you can do it intentionally like this. This is multiplane. नहीं आप यहाँ देखिए ये रहने दीजिए आप इधर. ये डिफॉर्म टिबिया है यहाँ पे. ये यहाँ पे डिफॉर्म्ड है. इसको मत देखिए आप. ये यहाँ पे लाइन अप था. अब ये एक्सटर्नल चला गया. यहाँ मत देखिए. इन्होंने डिफॉर्म टिबिया लाया है फॉर अ सेपरेट वर्कशॉप. So right. So see, he has done a great job. Dr. Subramaniam has done this great job. He's attached this over here. Yes. So we're going to wind up. So you attach the multiplane hinges so that the threaded rods are parallel. Okay. And then you can compress or translate. So thank you all. Thank you very much. Thank you, Professor Rajat. That's the end of the FDO workshop. Let's move on.